Hello everyone, my name is Jacqueline Nicole Muniz and I am a DNP student at Palm Beach Atlantic University. Today I will be discussing graft-versus-host disease as it pertains to our current study of diseases of immunity. In this case study pertaining to graft-versus-host disease, a 24-year-old man with chronic myeloid leukemia in chronic phase received high-dose cyclophosphamide and total body irradiation followed by an infusion of allogenic stem cells from an HLA-matched unrelated donor. The donor was female and was gravida 3 para 3. Further post-transplant treatment consisted of cyclosporine by continuous infusion and methotrexate intravenously on days 1, 3, 6, and 11. The post-transplant course was complicated by severe pancytopenia, moderate mucositis, and fever, requiring treatment with broad-spectrum antibiotics. On day 15, the patient had early signs of marrow engraftment. Circulating neutrophils were noted on the peripheral blood smear. On day 17, the patient developed hyperbilirubinemia, profuse diarrhea, and a maculopapular rash on his face, trunk, proximal extremities, palms, and soles that involved approximately 70% of his body surface area. This rash is indicative of graft-versus-host disease of the skin, but it is important to rule out infection due to the fact that immediately after transplant, infection is a major risk factor. The host marrow and immune system are suppressed due to conditioning regimen used for the transplant, in this case chemotherapy and TBI. Special support in these cases should include antibiotics and isolation from microbes by placing patients in laminar flow rooms. Biopsy specimens of the skin and rectal mucosa were obtained. A patient with GVHD of the GI typically presents with profuse diarrhea. Dilation of the mucosal glands is the first change. In severe cases, colonic epithelial damage can result in bloody diarrhea. This explains the decision to biopsy rectal mucosa in addition to the patient's skin. The patient was treated with methylprednisolone 2 mg per kilo per day intravenously. Within 1 week, the hyperbilirubinemia, rash, and diarrhea had improved. The methylprednisolone dosage was slowly tapered to 1 mg per kilo per day, and this, along with cyclosporine, was continued for several weeks, but could not be tapered further because of the flare of rash and diarrhea. At day 20, the patient received a 2-week course of ganciclovir for cytomegalovirus prophylaxis. At day 40, he developed fever to 102 degrees Fahrenheit with shaking chills. He was started empirically on broad-spectrum antibiotics, and a blood culture drawn at the time of the temperature spike revealed Pseudomonas aeruginosa. With antibiotic therapy, the infection cleared. By day 100, the patient's clinical status was stable, and the methylprednisolone was tapered to 1 mg per kilo every other day without any flare in rash, diarrhea, or hyperbilirubinemia. It is extremely important to understand the pathophysiology of graft-versus-host disease in order to grasp its effect on immunocompromised patients post-hematopoietic stem cell transplant. We can also use this knowledge to further research prevention and treatment methods. According to Blazer, Murphy, and Abedi, current data implicate the innate immune response as being responsible for initiating or amplifying acute GVHD. Molecules such as bacterial lipopolysaccharide that are released from the injured gut during the conditioning regimen activate innate immune receptors, including toll-like receptors, and cause a cytokine storm. This cytokine storm is an alloreactive donor T-cell-mediated response against the tissues of the recipient. These cytokines further promote antigen presentation and the recruitment of effector T-cells and innate immune cells, which further augment the pro-inflammatory cytokine milieu. Finally, the effector T cells, natural killer cells, macrophages, and pro-inflammatory cytokines, such as tumor necrosis factor, result in end organ damage, which is clinically recognized as acute GVHD in the skin, lungs, gut, and liver. The resulting tissue damage, if not treated, will further amplify the process to more severe stages of GVHD pathology. It is important to note that acute GVHD normally occurs during the first 100 days following hematopoietic stem cell transplant and generally targets the skin, mucosa, lymphoid tissue, gastrointestinal tract, and liver. GVHD can also present in the eyes, although rare. In relation to this case study, I will discuss the skin, GI tract, and liver. The skin can serve as a useful early warning system for acute GVHD. The characteristic rash generally appears within 6 weeks of transplantation. The rash initially appears on the palm, soles, and which can spread to involve the limbs and trunk and may be painful. As far as the gastrointestinal tract goes, the main sign of GI involvement is diarrhea. Woodward does an excellent job of describing the management of fecal incontinence associated with acute graft-versus-host disease. Treatment of diarrhea associated with GVHD includes using medications to reduce the symptoms, including antidiarrheal agents and high-dose steroids to suppress the immune system, and the use of dietary manipulation. High-dose corticosteroids are used as first-line treatment for GVHD. The damage to the mucosa of the gut and administration of immunosuppressive medications means that these patients are at significant risk of gastrointestinal infections, such as cytomegalovirus or C. diff. As mentioned in the case study, the patient is started on ganciclovir for CMV prophylaxis. We note the high risk of infection when the patient develops fever and a positive blood culture on day 40. As far as dietary manipulation goes, there are typically 5 steps. Step 1 is total bowel rest. A patient could be started on total parenteral nutrition at this time. Step 2 is the commencement of fluid intake with isotonic, low residue, and lactose-free fluids. Step 3 involves the reintroduction of low lactose, low fiber, low fat solids, and to avoid gastric irritants. In step 4, one can gradually introduce other foods as tolerated. And finally, in step 5, the patient may resume a regular diet, but may remain lactose intolerant. In addition, skin care is vital in order to prevent irritation and infection as much as possible with the management of fecal incontinence. Other GI symptoms include nausea and vomiting. This can also lead to anorexia, malabsorption, and weight loss. In extreme cases, bleeding, painful cramping, and paralytic ileus can occur. As far as the liver, we would see an increase of liver enzymes, including the ALP, cholestatic jaundice and clinical jaundice, hyperbilirubinemia as stated in the case study, and lymphocytic infiltration of the liver. When it comes to prevention and treatment of graft-versus-host disease, there are numerous agents available. Some of the approaches mentioned by Blazer, Murphy, and Abedi that have been used in clinical trials include small molecules, antibodies, fusion proteins, agents that affect the microbiome, cellular therapies, cytokines, and chemotherapy agents. In this case study, we learn of several agents utilized to prevent and treat graft-versus-host disease presented by the 24-year-old man with chronic myeloid leukemia. Cyclosporine and methotrexate were utilized post-transplant for GVHD prophylaxis. Once the patient developed acute graft-versus-host disease, methylprednisolone was initiated for treatment. There are currently several pharmacological agents that target donor T-cell activation and are routinely used for allogenic hematopoietic stem cell transplant recipients. These include calcineurin inhibitors, antimetabolites, and lymphocyte-depleting agents. Cyclosporine is an example of a calcineurin inhibitor, and methotrexate is an example of a chemotherapy and antimetabolite that targets T-cell signaling pathways. Ram and Storb explain the mechanism of action of cyclosporine and methotrexate used as a preventative measure towards GVHD and explain how corticosteroids are typically utilized in the treatment of acute graft-versus-host disease, as noted in the case study. Cyclosporine blocks the calcium-dependent signal transduction pathway downstream to the T-cell receptor and consequently inhibits the production of IL-2. A common regimen includes a loading IV dose of 3 to 5 milligrams per kilo per day, starting on day -3 to day -1. Dose is adjusted according to blood concentrations, and the patient is switched to PO form when he is able to tolerate food. Methotrexate inhibits cellular growth and division. Thus, the proliferation of antigen-activating T cells is inhibited. The cytotoxic effect is by inhibiting dihydrofolate reductase, and by this it inhibits purine and thymidylate synthesis. Common regimen includes methotrexate administration on day +1, +3, +6, and in some institutes also +11. Dose should be adjusted to creatinine and bilirubin levels. One of the major side effects of methotrexate is mucous membrane toxicity. This would explain the patient developing moderate mucositis post-transplant. Finally, methylprednisolone works by binding to cytosolic receptor, translocation into nucleus, and activating glucocorticoid response elements that regulate certain messenger RNA expression. By this, steroids have a direct lymphocytotoxic effect and downregulation of pro-inflammatory cytokines. Common regimen is methylprednisolone or prednisone, 1 to 2 milligrams per kilo per day. Patients should be weaned accordingly as mentioned in the case study. Other agents mentioned by Ram and Storb included mycophenolate mofetil, ATG, sirolimus, alemtuzumab, and cyclophosphamide. Cyclophosphamide is given post-transplant, typically on days +3 and +4, at a dose of 50 milligrams per kilo per day, based on the drug's effectiveness against activated donor T cells. This concludes my presentation on the pathophysiology, target locations and symptoms of disease, and the common prevention and treatment regimens of graft-versus-host disease. Thank you.